Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back to the Rural American Surgeon. I'm joined today by Dr. PJ Reddy, and he has a wealth of experience from a long history as a rural surgeon in Kansas. So thank you very much for joining us today, Dr. Reddy.
Thank you very much. I appreciate it. You're so kind. My name is Dr. PJ Reddy, and I graduated from medical school in India, and I did 1 year of, it's called house surgency. That means internship. At least in those days, they won't give you a certificate until you do internship also, which I did. So after finishing 1 year of internship in India, I came to this country. I came in 1967. And after coming here, I did 1 year internship in New York. After that, I did residency in surgery for 4 years in New York. And after finishing surgical residency, I also did 1 year of plastic surgery, fellowship in plastic surgery for 1 year. Mm-hmm. That was done in upstate New York. That means Syracuse. Mm-hmm. Syracuse, New York. I was there for 1 year. And then I was thinking of going into practice. I wanted to practice for a few years before going back to India. In those days, people either going to group practice or solo practice. Mm-hmm. In my case, I was not sure if a patient come to see me or not, since I come from a foreign country and I do not have a white skin. And then I saw an advertisement in a medical magazine. There's a small town in northwest Kansas called Hill City, and they're looking for a doctor. And so I want to be employed. Instead of going into practice, I better go into, a place where I'm employed.
Sure.
So I flew from New York City to Kansas City to Salina to Hayes, which is 55 miles from Hill City. And I landed in Hayes, Kansas. And to my surprise, the CEO of the hospital came to receive me. And the CEO of the hospital took me from Hayes to Hill City. In Hill City, I had an interview with board of directors, hospital board. And they looked at my CV and all that, and they asked me to sign a contract for
on
2
the spot.
years. Yeah, on the spot. So I signed contract for 2 years. And, it didn't take too long for me to find out that patients do not care much about your skin color. Mm-hmm. They care about what kind of, treatment management you give. Mm-hmm. And it didn't take too long to have my schedule full. Mm-hmm. Within a few days or within a week or two, my schedule was full. Mm-hmm. And at the end of 2 years, and then they asked me to sign for 3 more years. And I did sign contract for 3 more years. And then the CEO of the hospital showed some figures to me. Doc, we are paying you this much salary. But if you go on your own, you'll make more money. So he recommended to me to go on my own in Hill City. Mm-hmm. I said, all right. So I went on my own. There's another doctor. So 2 of us, are on our own practice. And like that, the thing is, the roots get deeper and deeper as you stay long.
Right.
My youngest, my first child was a year and a half at that time. And they started going to school there. And then they had two more children after that. And they started going to school. So, and the people, are naturally, they would like me to stay. So you may not believe, I was there in that small town for more than 40 years.
Wow.
41 years.
It's incredible.
And my two sons and one daughter, both sons have become doctors. They went to
Wow.
school in Hill City, and then they went to college, and then they went to KU Medical Center. So both of one is a neurologist, and the other son was an oncologist. And my daughter, she did graduate, in speech therapy, but her husband is an oncologist. So my two sons and my daughter and my son-in-law, they're all physicians.
That's a beautiful story.
Thank you. And then, after staying for so long, I thought of retiring, and so we moved to Wichita, Kansas, because in Wichita, my older son and my daughter, they live in Wichita.
Mm-hmm.
So to be closer to children and grandchildren, we moved to Wichita. And then after coming here, I was kind of getting bored. I want to do some work. There is what is called Western Medical Center in Wichita. Mm-hmm. Western Medical Center. And there they have got a wound care clinic. Care clinic. And they wanted somebody to take care of the patients in a wound care clinic.
Yeah.
Since I'm a surgeon, they took me right away. So I did
overqualified.
And it was a part-time job, of course. So I did work part-time for 2 years.
Okay.
Wound care clinic at Western Medical Center.
Sure.
And then the pandemic came, COVID-19 pandemic. Mm-hmm. Everything was closed. So I quit working after that. Well,
that's quite the story.
One more thing. I did do some volunteer work. There is a clinic here. It's called a Mayflower Clinic. Okay. And the Mayflower Clinic, it's meant for people without health insurance. Okay. And I did volunteer there for a few years. Sure. And they gave me an award also, for working there.
That's very nice. So I did a little web search on Hill City, Kansas, and it says that the population's around 1,600 people. Does that sound about right to you?
It went down. It used to be 3,000. When I was there, it was 3,000. The county was about 5,000. Okay. So we used to get patients from this, neighboring towns and for the whole county, and sometimes from the neighboring counties also. So they all kept me busy.
Yeah. So when you started there, you were the only surgeon in town?
Yeah.
And were you the only surgeon the whole time?
That's right.
Were they able to replace you after you retired?
No, not really.
How's the hospital doing since then?
Well, they have a surgeon coming to Hill City, I think, once in 2 weeks. Mm-hmm. And if an emergency, then they transfer the patient to neighboring town.
Sure. Yeah, that's a common story. But basically, the hospital recognized your value, and the CEO came out to meet you, took you straight to the board, and they said, give you a job offer on the spot. I think that's still happening in the small towns that have managed to remain independent. A lot of these small hospitals have been purchased by a bigger system who then no longer, like maybe they bought the hospital thinking that they could buy the stream of referrals, not so much thinking, how can we offer more services here in this small town? So the Hill City Hospital, is that still independent or have they been conglomerated?
That's a good question. I found out that after I left, the income has gone down for the hospital.
Sure.
because they were not doing any surgery and all that, and the income has gone down. And the hospital CEO, a lady, she's a CPA. There is what is called community hospital, something like that. It became a COH, a community hospital. By that way, the Medicare will pay. If you lose money, the Medicare will reimburse the hospital.
Mm-hmm.
If you make money, you have to pay it back to Medicare.
Are you talking about a critical access hospital?
Yeah, correct. Yeah, CAH.
There you go.
Yeah,
there
I
you
couldn't
go.
get the name. CAH.
Yeah.
So the hospital became CAH, a
Yeah.
critical access hospital, after I left. I think maybe when I was there also, they started the CAH. You're right.
Yeah, that's a
So since it's
very...
a CAH, since it's CAH, they didn't have to close the hospital.
Did you say they will never close the hospital?
Because it's a CAH, as you know, when it's CAH, then get the money from the Medicare.
Yeah, so they get paid
That's
at cost,
what I heard,
basically at cost. So they'll never close the hospital unless the CAH program goes away, right? So now they're extremely dependent on that. We've lost
to
a
my
lot of...
knowledge, that's what I heard,
Yeah.
If you make more than you spend, you have to pay the money back to Medicare.
Sure.
And but if you make less, and so you'll get the money back from Medicare.
Yep, very good. Well, that is just a great introduction, and I wanted to just say thank you for being involved on the Rural Surgery Listserv. That's I would say, a small group, but it's always fun to hear different perspectives. And I actually met you through the listserv, and you were talking about your rural practice and sort of saying some inspirational things to a young rural surgeon, and I appreciated that. And so I invited you to come on the show, and I'm really thankful that you did so. And the first question that I ask every guest is, why is rural surgery special to you?
Well, one thing is that they kept me busy. Rural surgery kept me busy. If I'm in a big city, I do not know how busy it will be. It depends. There are so many surgeons, and I was the only surgeon there, and they kept me busy. I think I also did OBGYN.
So we're going to talk about the how I do it for the show, and today we're going to be talking about colonoscopy. So we're going to talk about specific tips and tricks, but also have a focus on how you learned this skill after your residency training. And so tell me what your exposure was to colonoscopy in residency. And I am sitting actually in the building that I went to my 8-day well child visit on. And I found my paper chart in the basement. It's a clinic that I was able to purchase and start a practice out of. That's a long, complicated story. But long story short, I guess what I'm trying to say is there are a lot of medical textbooks that were some of the previous doctors that used to work here. They're still here in the building. And one of those books was a book on colonoscopy from the late 1980s. And I just cracked that book and was looking through it, just wondering where the perspective was at that point. And I remember reading, it says, colonoscopy is a good tool for certain circumstances, maybe for high-risk people for colon cancer. You could consider using it for screening, but it should never be offered for screening for the entire population due to the cost and the technical difficulties. And, there's limited access. So that's where we were like in the late 1980s. And obviously now screening colonoscopy for everybody, multiple times throughout your life, starting at 45 now. And so you finished med school, came over here in the late 1960s, and you've just witnessed insane change during that time. So what year did you actually go to Hill City?
1973.
Okay. And so you're there for 41 years. And did colonoscopy even exist? Like when did it start? I can't remember.
Well, that's a good question. I think it started in late 80s, 88, 89 in that.
Mm-hmm.
And I started doing in 1995.
Okay.
I think I think I wrote somewhere here. I think in 95 maybe I did the first scope. Well, I heard about this colonoscopy, and I think I think I told you. Well, there is a town called Salina. Salina is about maybe hour and a half drive, maybe 2 hours drive from
Mm-hmm.
Hill City. There's a gastroenterologist over there.
Mm-hmm.
So I went to the gastroenterologist. I saw him, how he does the colonoscopy
Mm-hmm.
and also gastroscopy both.
Okay.
And then I met, I went to Wichita, Kansas, and I met a gastroenterologist. He gave me a video of how to do colonoscopy. And
Mm-hmm.
I took it home and looked at that video and all that. And then I started doing colonoscopy in Hill City.
Okay.
So that's how I learned, from
What
the
kind of volume
gastroenterologist.
did you have to watch in order to kind of to see? And then did you have anybody come to Hill City with you, or did you touch any actual patients? Were you able to actually do any
Well,
colonoscopy somewhere else?
no, I did it myself alone. I mean, we have a nurse anesthetist
Mm-hmm.
coming and giving anesthesia to the
Mm-hmm.
patient. And then I did the scope. I think I did more than 500 scopes, colonoscopy, more than 500. And then I also did, I think I told gastroscopy also.
Mm-hmm.
I think more than 1,000 gastroscopes.
Yeah. So just doing a little quick Copilot web search here. What I'm finding is, they always say, oh, the history of colonoscopy dates back to the 1800s, right? But it doesn't really. Modern colonoscopy started like in the late 60s, leading from some upper scope successes. And then by the 70s, it was standard to diagnose colon cancer. And of course, I told you about the book from the 80s. So gradually throughout the 80s and 90s, it became important for screening now and preventative care. I also found that I'm not sure if this is, somebody might have to fact check me on this, but what I'm seeing is that the flexible endoscopy curriculum was started only in 2017. Which sounds right. That's when I was in training. But I'm sure the numbers for training were before that. You just didn't have to do the FES curriculum.
You mean flexible sigmoidoscopy?
Yeah, like there's a specific curriculum. There's fundamentals of laparoscopic surgery, and then there's now fundamentals of endoscopic stuff such as colonoscopy. So we use like a trainer and everything. And so, but to graduate residency, you only need 50 colonoscopies and 35 upper scopes in order to graduate. And if you're a surgeon and you're technically capable, you're doing bronchs and other things using scopes, I guess I see that as maybe a minimum number to have an exposure. But I don't know, if I would do 50 and 35 and I was bare minimum coming straight out, I probably wouldn't be ready to navigate some of the difficult colons that I see in practice. And so I guess I'm just wondering how that was for you to get through your first couple dozen, and become more technically proficient over time. Like that seems intimidating to me. And
Well,
I'm wondering how your perspective.
Practice makes perfect,
Sure.
As you keep doing, the more you do, it takes less time.
Yeah. Yeah, that makes sense. And then in terms of trying to not create complications, how did you manage that early on? Just take your time?
Fortunately, I didn't have any complications, but I think in a couple of cases I was not able to put the scope into the cecum, and I think the patient stricture in the sigmoid colon or something like that, and I didn't go through. And in another case, I couldn't go through the sphenic flexure. So there are a few cases I was not able to go through into the cecum, And when that happens, I send the patient to another surgeon, in neighboring town. That means Hayes or Salina.
And they were usually able to get through?
Yeah, I think, if I remember right, I think in one case, that patient had maybe cancer, something like that, a large tumor,
Sure.
No.
Very good. So what are some of the, like if you were teaching somebody else, hey, I learned this or that trick for colonoscopy, what were some of the best tricks to your technique that helped you get through a difficult one?
Well, I tell them just go slow. Don't push it in, push the scope in, just go slow and try to manipulate and
Yeah, sometimes when you're pushing in, you're actually kinking on the inside and dragging the scope with you. And when you pull back, it actually straightens the whole thing out, and you just see the lumen, and you can fall in a little bit easier. It's kind of like pushing your sleeve up on your shirt,
right.
But it's not totally intuitive, and I think it's a different skill set than surgery entirely. So it's kind of like I don't know, riding a bike and riding a skateboard. Just because you can do one doesn't mean you can necessarily do the other.
Yeah.
Not that I know much about skateboarding, but very good. Anything else about colonoscopy that you'd like to share with my listener?
Well, you see some diverticuli as you do the procedure, and you do polyps, diverticuli and polyps, and most of the times, as you know, the polyps are benign, but we never know until we do the biopsy or excise, and it depends upon the type of the polyp. If there is a pedunculated polyp, you can put the wire and then get the whole thing out. The polyp,
Sure.
Pedunculated, and otherwise, if it is flat on the surface, and then you do a biopsy. Sometimes you can have perforation of the colon, so you need to be real careful when you do the biopsy. And the other thing is, when it comes to hepatic flexure, the scope, you have to be real careful, so you don't want to go into the liver in a hepatic flexure. So,
sure.
That's all I can tell you. Go slow and see what you can do.
Yeah. So I would say that I've seen there's two different types of, I've seen a lot of different complications, both as a resident, managing other people's complications, and seen some in my own practice. You can do a lot of damage with traction. Like you can cause a splenic capsular tear, manipulating the scope. When you're talking about perforation, it could happen, removing a large polyp, but the other one potential complication is you actually perforate with the end of the scope, trying to push forward, which means you're probably using too much pressure. Or if you're pushing through a big loop, you can actually perforate out the side of the sigmoid colon, and then you'll hopefully catch that on the way back, or you might feel that. Now they used to do X-ray, like a live fluoro when colonoscopy was first coming out. But now there's actually a technique or a device called the scope guide. Have you ever heard of the scope guide?
No, I heard about the CT scope.
No, this is different. This is non-radiating. It's magnets that actually are within the scope. Oh. And I'm not really sure how it works, but there's a little flat panel that kind of sits on a little cart, and it can go over the patient, and you can see down in the corner, it looks like a fluoro. You can see the shape of your scope, and you can even see there's pressure sensors on it too. So if you're feeling a lot of pressure at one spot, it'll turn yellow and kind of show you. I think that's a good trick if there's somebody that's considering adding colonoscopy. First off, finding mentors, doing courses, and then consider using the scope guide, because it'll show you that picture. You'll see when it's looping, then you pull back and you're trying to have the nurse hold pressure to pass it through straight. You'll see if it's working or not, or if it's starting to form the loop, just an idea.
Sure.
Yeah. Why don't we move on from colonoscopy, as much as we love talking about it, and let's go to the next segment of the show called our financial corner. So I was wondering if you had a money tip for our listener.
Many students have $100,000, $200,000 loan, something like that. So once they start doing residency, they have to think of paying the loan out,
Yes.
And fortunately, in my case, that was not the problem.
Yeah.
And my children also did not have that kind of problem,
But what would you do if you were graduating? I think actually the average is now like 250 or 300,000. That's the average, meaning some people have 400,000 or more. So what if you're graduating medical school right now, going to residency with $300,000 of student loan debt? What would you do?
Well, the best thing is to spend less. I mean, don't buy a Lexus car.
Yeah, that's a good start.
I don't think they spend money to drink alcohol or things like that,
Yeah. Eliminate your vices.
And when I started doing internship, my salary was $6,000 per year, $6,000.
Wow.
And residency, it was a 10,000 first year residency in those days. But now, to my knowledge, from what I heard, I think $60,000 residents, first year resident for 6,000, something like that.
It's probably close, yeah.
Yeah, so maybe they can use 25% of it to pay off their loan. And
sure.
The other thing is how much interest you have to pay for the loan. There are some loans you have to pay at, say 8%, 9%, something. You pay off that high interest. Maybe it's better to sit with a financial advisor.
Yep.
And see what they recommend.
So I'm just doing some quick math. Say you graduated with $300,000 student loan debt, and it was federal debt, so it's at 6%, say. And a lot of people probably in a worse situation. Well, that's $18,000 of interest only. So if you have a $60,000 salary, and you paid a quarter of that for your loan, then you're paying $15,000 a year, right? So you're actually getting behind on the interest during each one of those years. So I'm not sure that they can solve, there's a lot of different strategies. What I love about your answer is you started by saying, stop spending, stop the madness. Okay. That's not the time for you to buy the Lexus car. You didn't say like, here's a big stock tip so you can get rich quick. And you didn't even mention public student loan forgiveness, which is a program that probably should be used by some of these people where you work for a nonprofit or government entity of some sort, and you can get loan repayment. You also could sign on with the military, but you didn't mention those specific tricks. You started with like the fundamentals. If you don't control your spending, you're never going to get out of debt, right?
Yeah.
Because
that's a good point. The thing is, in the state of Kansas, if you do work in a rural area, then they'll pay off the loan, some of it or all of it, something like that. I know some doctors here in Kansas where they work in a rural area, they work for 3 years. 3 years.
Yeah.
If they work for 3 years, then the loan is paid off. That is something to keep in mind.
Yes. And that's where I was hoping we were going to go, because it is a rural surgery podcast after all. So I think going to work in a rural area, whether it's through an official government program or just a hospital recruitment strategy where there could be some student loan repayment as part of an exchange for time, is a great strategy. And I think that there's a huge need in rural America. And if you can work that to your advantage, go for it. But I would say one more thing about this topic. I think if I would have went back to being a medical student and I would have maxed out my student loans for living expenses and everything that I possibly could have the whole entire time, and I would have invested that money, and then on the backside done public student loan forgiveness, I think I would have been actually money ahead. But the only reason is because I went to medical school in 2011, right? So coming out of the big recession, I existed during a time which is one of the longest sustained bull markets in history. And that's not guaranteed, but there is a sense of security of not having any debt, and student loan debt I had some, but it's gone now, and it's non-secured debt. So like if you have a debt on a property, at least you can sell the property as long as you have enough of an equity cushion, but you can't sell anything to pay off your student loan debt. It's just there. And the only thing you have is you need to work it off because it was for you to get the education that you got. So I guess my advice would be to minimize your debt, even though like in looking back, I probably could have been money ahead, borrowing money at 6% and investing it. I think that would have been a poor choice, and I'm glad I didn't. And I encourage you not to do that as well. Just minimizing the debt in the first place.
That's right. Yeah. Maybe it's better to talk to the financial advisor. I don't know.
I think that's a good point to say that this is more or less a entertainment podcast, and I'm not a financial advisor, and I agree that you should talk to somebody that's a fiduciary and who is licensed and all that stuff. But some of the core concepts of what we're saying, like don't take out debt. I mean, that's not like a stock tip. I think it's fine to tell people that. All right. I love it. Let's move on to the next segment of our show called Classic Rural Surgery Stories. So these are stories that your urban counterpart just wouldn't believe. Do you have any stories like that you could share?
In a neighboring town, there's a surgeon there. I used to call him to assist me in major cases. So that surgeon used to come to assist me. So we are two doing major surgery, like colon resection, things like that. So that was helpful. And I told you that I was doing OBGYN also. So my colleague, family practitioner, he was assisting me for, C-sections, things like that, emergency. Yeah. So I used to get some help from other people also.
Any particular stories from any of those surgeries that really stands out to you as just, you would never believe this?
Well, fortunately, I did not have that many complications. Two cases, laparoscopic cholecystectomy, lap chole. There was damage to the common bile duct. So I had to send them to another hospital for that. For perforation of the common bile duct. And so
how did you identify that? How did you identify that?
Well, you do lap chole, you send the patient home. The next day, the patient comes back, doc, I'm still having pain, and then the abdomen is swollen, tender, things like that. Then you do a CAT scan. When you do CAT scan shows some fluid near the ascending colon,
Yeah, that's a giveaway.
That means, there's a bile leaking.
Sure.
And then send them to a tertiary bigger hospital.
And then an ERCP to follow that with stenting, and that solved the problem?
Well, the ERCP stenting, I had one case. I was doing a gastroscopy. There was a perforation of the distal esophagus. and I had to send the patient to bigger tertiary hospital, and they put a stent, and
Yeah.
and that was there for 6 weeks or something like that. So everything went well, no problems at all.
Yeah. How about the bile duct injury though? Was there a
Bile duct injury.
ERCP?
I think that patient, they did choledochoduodenostomy,
Okay.
choledochoduodenostomy, like that.
Yeah. Yeah, that sounds good. Well, thank you for those stories. The last segment of the show is resources for the busy rural surgeon. Do you have one resource that you used regularly that you think every rural surgeon should know about?
Rural surgeons should be familiar with DNC, hysterectomy, C-section, things like that. In a rural area, we never know. I would like the residents to get some training in OBGYN also.
Mm-hmm.
And also, they should learn how to do tonsillectomy, TNA and all that.
Mm-hmm.
In a rural area, TNA, they can rotate through ENT department and learn to do TNA and maybe thyroidectomy,
Mm-hmm.
parathyroidectomy. I did all those cases, and in general surgeons, they do only abdominal surgery and herniorrhaphy and breast cases, of course.
Mm-hmm.
I don't think they'll do that much, ENT. So they should learn all these surgeries also. And the other thing was, I had many textbooks of surgery at home, and if I have a patient for a parathyroidectomy, I read the night before
Yeah.
and look at the anatomy and all that, and see how to do parathyroidectomy or for thyroidectomy and all that. So
Sure.
I think it's a good thing to have the books at home, surgical books, operative procedures, I mean.
Yeah. Yeah. And now in the days of laparoscopic and robotic surgery, there's an element of video too that you can watch.
Yeah, sure. Okay, video. Okay.
So that's good. I do the same thing with textbooks. Now, I want to ask, is that a habit that you started in training to read from the textbooks the night before to prepare for your cases?
In training, I did not do that many cases. That's why I bought the books, operative procedures.
Mm-hmm.
I can show you if you want me. There's one right here.
Yeah, sure.
Well, this is about Atlas of
Color Atlas of Human Anatomy by, who is the author?
Yeah.
McMinn and Hutchings.
And then I had surgical procedures also.
Yeah.
I had surgical procedures, and I also had, CSAP.
Sure.
CSAP.
And so, Dr. Reddy, how old are you now?
What's your guess?
Well, let me do some math. If in 67 you came here and you're already done with med school, you had to be at least 20 something, like say 24, and then 41 years practice, and then 2 years after that, and then that was COVID and it ended. So let me see, 48 plus 24. I'm going to say you're 82.
82, you're right.
Wow. Geez, I think I should be a detective. Quit the surgery and the podcasting business and be a detective or a mathematician.
You're right.
All right. Well, it's a beautiful picture of an 82-year-old surgeon that's still academically involved. At least you're involved in our society. You're never not a surgeon. It's very similar to being a pilot. You might give up your license. You might give up your medical. You might not be board, may give up your board certification. You may not be practicing, but you're always a surgeon. And I appreciate you taking the time to share that experience and that knowledge with me and with the younger generation today, it's really meaningful to me. So I really appreciate it.
Thank you. I still have the medical license. And there is Osteopathic School of Medicine here in Wichita. Mm-hmm. And sometimes they call me to teach the students how to suture, suturing. And so I do that. And so I keep myself active. I read before that empty mind is devil's mind.
Thank you for joining us for this episode of the Rural American Surgeon Podcast. We appreciate you being a listener. It's been my pleasure and honor. It's been nice to have Dr. Reddy to show us what a great career in general surgery can look like. So thanks again for joining us, and we'll see you on the next episode of the Rural American Surgeon Podcast.